And hello, everybody. Good afternoon. Today is the part one of a two-part session on mental health and mental illness presented by Dr. Marissa Martz, who is the staff psychiatrist at Pine Rest Christian Mental Health Services. Dr. Martz received a Bachelor of Arts degree from Hope College. Her MD is from Michigan State University, and her residency in psychiatry is from Brown University. And an interesting side note for you to get to know Marissa a little better. She's a newlywed, recently married this summer to Dr. Rick Gonzi, who is a prominent anesthesiologist at Holland Hospital and also a friend of mine. And both Marissa and Rick are marathon runners, they're athletes. Rick is also a hockey player, a former teammate of mine. And will be running the Chicago Marathon this weekend, and they have run both the Boston and New York marathons in the past. However, she's here to talk about mental health and illness, not about marathons. And so for those of you who are on video, please, if you're going to do any activity that would be distracting, turn your video off. If you're not speaking, turn your audio off, mute yourself. And if you have a question, go on video, you can raise your hand or you can type it into the chat room and I will moderate that and we will ask questions as we go along. And I think that is all I need to tell you. So let's turn this over to Dr. Marissa Martz. Thank you.
Thanks, John. I'm really excited to be here with you guys. And like John said, we're going to talk over this week and next week about mental health and mental wellness, mostly focusing on mental health as that's what I do as a psychiatrist. But yeah, going back to my background from Hope College, so go Dutch. Excited to be back in West Michigan after being out east for some time. So I just want to give you a little bit of an idea of what I do, where I'm coming from. So I work at Pine Rest and I'm an inpatient psychiatrist there, which means that I treat patients who are admitted to the hospital. Pine Rest is a big place, and so there are different units that have kind of different specialties. So my specialty is more for people who are experiencing psychosis or mania, and we'll talk a little bit about what psychosis means. But so kind of a more acute population than kind of depression or anxiety or things like that, which we'll also talk about. Um, Today, we're going to take kind of a broad overview of a little bit of the history of mental health treatment in the world and in the United States, and then talk about some of the most common kind of psychiatric illnesses, and then talk a little bit about kind of maintaining mental health. Next week, we're going to talk about mental health and mental illness in the older adult population. And I'm not a geriatric psychiatrist. I'm not trained as a geriatric psychiatrist, but we work with patients of all ages. And so going to tap into some geriatric psychiatry to talk a little bit about that. So without further ado, let's go. So I have no disclosures to mention apart from I do work at Pine Rest and I may kind of mention Pine Rest. I will have some medications listed in my presentation. I have no relationship with any of the makers of any medications. So, as I kind of talked about the outline, going to start out with the history of mental illness, starting with Hippocrates through Sigmund Freud to kind of the history of mental illness here in America and kind of where we are now with the DSM or the Diagnostic and Statistical Manual of Mental Disorders. Talk about a few of the most common mental illnesses or things that you may hear about. So, anxiety, depression, suicide, and psychosis, and then talk about some of the treatments for mental illness. So, from various perspectives, including biologically, psychologically, socially, culturally, spiritually, things like that. So, if we jump into the history of mental illness, we are going all the way back to kind of Hippocrates or even before Hippocrates. So, mental illness was thought to be due to some kind of supernatural or evil kind of possession of spirits and things like that, and were typically shunned by communities. There are even some really gruesome kind of paintings and things like that of people who were shackled outside of buildings, and so that's kind of how historically people were treated with mental illness. There are actually some cultures that people with mental illness were thought to have maybe a special spiritual connection and were sometimes regarded as leaders in that those cultural communities, but more often than not they were shunned from their communities. If we look back to the 5th century BC, Hippocrates, we know him well for being involved in medicine in general. And he kind of talked about how different body parts might be able to kind of interact to cause mental illness. And so hysteria actually was noted in one of Hippocrates' writings. And hyster is from the root, or is the root for uterus. And so there's actually kind of a writing called On the Diseases of Women that Hippocrates wrote. And it talks about the wandering womb, that the womb can move towards the head and cause suffocation, sleepiness, foaming at the mouth, or towards the upper abdomen, causing drowsiness and loss of voice. And then if the woman's uterus moves towards her liver, she will suddenly lose her speech, grind her teeth, and take on a livid coloring. So there was this attempt to describe what is happening with mental illness. Of course, these aren't our ideas anymore, but there was this attempt at trying to make sense of this. And there was these ideas of the four biles, and there was this thought that buildup of black bile could lead to melancholy or more that depression. And so back in the 5th century BC, mental illness was being recognized as something that was out of the norm and trying to be explained. If we fast forward many centuries, we get to Sigmund Freud, who is kind of thought to be the father of psychiatry. However, he was a neurologist and he was living in Austro-Hungary, and he had kind of this private practice where he was seeing a lot of kind of medical people coming for medical help, but they didn't have any physical basis for why they were coming. And back in the 1880s is really when he started his work. And there are a lot of kind of theories that have come from Freud, many that we don't kind of ascribe to at this point any longer, but there are still some pieces, and he was going along the right track with some things. And one of those things was childhood trauma, that that childhood sexual abuse or other abuse can certainly impact people's experiences throughout the rest of their life. And this is kind of one of his main focuses, that the abuse from childhood can kind of become a part of the unconscious mind, and with the unconscious mind that can present in physically ill symptoms. He talked about the psychosocial stages of development as well, from infancy to adulthood. Um, we don't really talk about those anymore, and that's not necessarily something that we think about a whole lot. But the point that we take away now is that children are not small adults. They have other things, other stages that they are going through, that adults have passed through. So children are not just kind of mini adults. His main treatment modality was talk therapy, and that is something that we very much use now, and has a lot of evidence to support it. And what he noticed is that people get better when they talk to a therapist. The therapist is listening, involved, has this kind of non-judgmental, unconditional, positive regard towards the patient, and that in and of itself can be a healing experience. Unfortunately, there were no medications at that time, but he did actually propose that there would be medications one day that would be discovered that could cure mental suffering. I don't know that we're quite there yet. I don't know that we found any cures, but we certainly have treatments, medication treatments that can treat mental illness. If we look at kind of the history of treatments of mental illness from a more biological standpoint, we're looking mostly in the 1900s. We didn't have anything back in Freud's day in terms of biological interventions. We certainly had the talk therapy piece of things that Freud was talking about. But in the 1930s is when lobotomies were happening. I didn't include a picture of that because it's pretty gruesome to look at kind of what they were doing with lobotomies. Of course, we aren't doing lobotomies any longer, and that wasn't a particularly effective treatment. But it was a little bit of a shot in the dark of, what can we do to help people who are really, really struggling with mental illness. In the 1930s, there were also these insulin-induced comas. Which we also don't do anymore, but they would give insulin to the point where the person's blood sugar would be essentially zero, and they would go into a coma because of this. And the problem with this is that some people never came out of a coma, and that other people, when they came out of the coma, they were very sedated or not quite themselves, but the mental illness wasn't necessarily treated either, and so they would put them in another insulin-induced coma. Once again, an effort to just anything to be helpful. First used in 1938 was ECT, electroconvulsive therapy or shock therapy. We do still use this treatment, and I'll talk a little bit about this later. But what happens with electroconvulsive therapy, you can see it in kind of the top left-hand picture, is that we apply electrical stimulation to the brain, and that electrical stimulation kind of changes or resets the nerves, the way the nerves talk to each other in the brain. It's not like one flew over the cuckoo's nest anymore. It's a much more civilized procedure. People are under anesthesia for a very short period of time, receive usually one electric shock to the brain. It induces a seizure as the electricity is resetting in the brain, but we have paralyzed them as part of the anesthesia, so they're not jerking all over the place like the one flew over the cuckoo's nest. The seizure usually lasts less than 1 minute, and then they wake up from anesthesia, and that's the end of their treatment. Typically, we do treatments 3 times a week for what we consider an acute series of ECT, which is usually for 2 to 4 weeks. And then we can do maintenance ECT, which is anywhere from once a week to once a month to continue the effect of ECT. But this is something that was used back when lobotomies were being used, but it is still used today and still considered one of our most effective treatments. In terms of medications, those are first kind of being introduced really in the mid 1900s. Lithium is a medication that we use for bipolar disorder, and it was actually kind of discovered, I would say, in the late 1800s, but then had fallen out of favor and was kind of rediscovered in the mid 1900s and then began to be used more consistently. We still use lithium quite often today. I have many patients currently that I'm working with who are on lithium right now. Chlorpromazine or Thorazine was our first antipsychotic medication, and that came out in the 1950s. So if you're thinking about kind of if we were treating patients with psychosis, which we'll talk a little bit about later, before the 1950s, we didn't have any particularly effective medications to be using. So it's really kind of grasping at straws prior to this. Since Thorazine came out, there have been many other antipsychotics that have come out that may have a better side effect profile, but we still do use Thorazine today as well. Imipramine is the first antidepressant medication that came out also in the 1950s. This medication is not used as often today. It's still on the market, but it's not used as often. It was kind of replaced by our other antidepressants like fluoxetine or Prozac, which came out in the 1980s. And that falls under the category of SSRIs, which we'll talk a little bit about later. But because of its side effect profile and how effective it is, that has kind of taken over since then, since the 1980s. And also, I think that the marketing has been very different for those antidepressants than some of the older antidepressants. And then I just added transcranial magnetic stimulation, or TMS, is another neuromodulation type treatment similar to ECT that actually came out in the 1980s as well, but has come more into favor over the last 10 years or so. That's the picture on the far right. Um, and what happens with transcranial magnetic stimulation is a magnet is applied to a certain part of the head, and the magnet induces an electrical impulse, once again kind of resets the electricity in the brain. It's a little bit more of a targeted treatment than ECT. People don't have a seizure; they are not under anesthesia for this treatment. Um, and can be used for more treatment-resistant depression. And we have that in a lot of the kind of bigger hospital systems. So Pine Rest does TMS. Your typical outpatient psychiatrist office would not do TMS, but it is an outpatient procedure that people come every day for several weeks to receive these short magnetic stimulation treatments. If we talk about kind of the history of mental illness in America, I think it's important to kind of talk about the waves that we've seen in terms of um, kind of in some ways what we do with people who are experiencing mental illness. And so for a long while, there was this idea of institutionalization. And in the 1840s, there was kind of this push towards funding more psychiatric hospitals, or what some might call insane institutions. And initially, that was welcomed by families and communities because patients otherwise were being shunned from their communities. They were living in dangerous, unhealthy conditions. They were unable to kind of take care of themselves. And in these psychiatric hospitals, they could be treated by professionals and supported in kind of all areas of functioning. Unfortunately, they were chronically underfunded, understaffed, and there were a lot of concerns for human rights violations and poor living conditions. So there are a lot of really terrible pictures out there of people living in these really underfunded, understaffed psychiatric hospitals. But by the 1950s, there were 560,000 patients institutionalized. So at that time, if we look back at the medication piece of things, the mid 1950s, we're starting to see medications come out that might be helpful for people who would otherwise be institutionalized. These people who have schizophrenia, psychotic disorders, the people who are severely and persistently mentally ill. And so maybe we might be able to treat these patients better, manage some of their symptoms, and maybe they wouldn't need to be in these institutions. So there was this push towards deinstitutionalization in the mid 1950s. Um, and a push towards outpatient treatment. Kind of these community mental health centers were made, and they were supposed to help support these people who would otherwise have been in institutionalized, but are now living in the community, to try to help support them in the areas that they needed to be supported. Um, because they had antipsychotic medications, that was often a part of their treatment. There were also these smaller supervised residential homes, now called group homes or AFC homes, that were developed to try to help support these people. Um, Unfortunately, this idea of trans institutionalization kind of came about in this movement because once again, these programs were underfunded and understaffed, and we were unable to support people in the way they needed to be supported. So rather than kind of transitioning them to the community and them being able to live a productive life in the community, oftentimes people kind of fell through the cracks and they landed in one of two places. One is in homelessness, in kind of this unstable housing situation where they're unable to get at least their housing needs met and probably many of their other basic needs. Or they were institutionalized in the criminal justice system. So they got picked up for petty crimes, drug charges, things like that. And instead of being in an underfunded, understaffed, poor conditioned psychiatric hospital, they're now in kind of the same thing, except for in a jail or in a prison. We still have very high rates of incarceration among the mentally ill, but that's usually not due to really violent crimes. It's usually due to kind of more petty crimes, substance use, and is really mainly due to a lack of affordable housing and kind of this underfunded community treatment. If we fast forward to kind of our classification now of psychiatric disorders, we have the Diagnostic and Statistical Manual of Mental Disorders, or what we call the DSM. Back in the day, though, as far back as the Greeks, they were trying to figure out diagnoses, and we actually look back into the 1880s when Emil Kraepelin, he was somebody who was trying to kind of understand these different disorders in terms of mental disorders, and he talked about this idea of dementia precox versus manic depressive insanity. What we would call those now are schizophrenia versus bipolar disorder. And what he was seeing is that they had different outcomes and their illness course looked different. And he was trying to kind of separate out to be able to see, especially once people were being kind of psychiatrically institutionalized, are there certain people who are going to require institutionalization for the entirety of their life? Or are there some people who might have these episodes where they require institutionalization and other times that they might function to a high degree? So this dementia precox is what we now know as schizophrenia, and it was kind of a progressive psychotic illness. Whereas this manic depressive insanity, people often return back to baseline, which was important to know when institutionalization was a big part of things. Um, in 1917, the American Medico-Psychological Association tried to start gathering some statistics from these mental hospitals. And the first edition of trying to classify mental disorders was published. And then it wasn't until the 1950s that the American Psychiatric Association, which still exists today, es- um, kind of established or put out the first edition of the DSM, the Diagnostic and Statistical Manual of Mental Disorders. Initially, it was really based on statistics, and just trying to kind of group together people who appeared to have similar presentations and similar symptoms, and kind of put them in categories. Now it's a little bit less based on statistics and a little bit more based on science, how we're categorizing mental illness. Um, and the most recent edition is DSM-5, which was released in 2013. There's been a revised version since then that hasn't made a huge change. But the DSM is now created by a panel of experts that come together and look at our current diagnoses and try to kind of break down if we have further evidence that these should be changed in some way. I will say that I think in my career, the DSM is going to change quite dramatically as our research in mental health is really advancing to include more kind of imaging like MRIs, functional MRIs is kind of one of the places that psychiatry is going. PET scanning, which is looking at how the brain is using glucose or sugars. And so I think that with that piece, the genetics piece, I think we're going to have a lot better idea of the biological piece of mental illness. And I think that we are likely going to move in a different direction in terms of the DSM. But right now, it's based on symptom clusters. So if we look at this is kind of a graphic, and the next one is even more kind of a lot. But this is kind of every diagnosis chapter in the DSM-5. And the what I wanted to kind of point out is that there are a lot of things here. So the ones circled are the ones that we're going to talk about today, but there are a lot of other things that you may not think would fall under necessarily the DSM-5. So things like feeding and eating disorders, elimination disorders, sexual dysfunctions, somatic symptom disorders. So that's physical symptoms that don't have any kind of biological or medical reason for them. Paraphilias, neurocognitive disorders like dementia, which we'll talk about next week. gender dysphorias, sleep-wake disorders. So there's a whole host of things that fall under um, in the DSM-5 and that psychiatrists work with on a day-to-day basis. So here is an even more overwhelming kind of slide, and it's not for you to necessarily read, but these are all of the diagnoses that are included in the DSM-5. And this kind of center square is the what I showed you in the last slide, and then it kind of balloons out from there. And these various types of disorders are broken down into various symptom clusters. So I'm going to move on to some common mental illnesses, but I wanted to take a second to see if there are any questions about what I've gone through so far.
Marissa, I have a question.
Yeah.
Uh, do you think that institutionalization is appropriate at all for certain patients?
Yeah, so that's a good question. I do, and there is still in Michigan, there are 7 state psychiatric hospitals that are not acute care hospitals like Pine Rest or other medical hospitals, but are rather places where people stay longer term. Some of that is forensically based, meaning that they have been arrested for some kind of crime and they are staying in, they have a psychiatric illness that is impairing their ability to proceed with a trial, or they're found not guilty by reason of insanity. And so they stay in a forensic psychiatric hospital. But there's also a civil psychiatric hospital, and there's one in Kalamazoo. And I do think that there is a certain small population that benefits from something like a state psychiatric hospital, which would be considered institutionalization.
Thank you.
Yeah. All right. So I will keep moving forward with common mental illnesses. So I'm going to start out with anxiety. I think that this is maybe the most relatable disorder because all of us have had some anxiety at some point in our lives. And I'm just going to go through some statistics. I'm going to go through the DSM-5 criteria. I'm going to talk very briefly about neurobiology, and then I'm going to talk about some treatments for anxiety. So if we zoom in on that graphic that I showed just a couple of slides ago, these are the anxiety disorders. So kind of separation anxiety we see there, phobias we see, social anxiety, panic attacks, agoraphobia, which is a fear of kind of leaving your house or being out in public, generalized anxiety disorders. So we kind of break them down a little bit. I'll be talking mostly about kind of generalized anxiety disorders. Starting with some statistics, though, here we can see the percentage of people experiencing mild, moderate, and severe anxiety. With this survey, which is through the CDC, over 15% of adults experience some symptoms of anxiety in the past 2 weeks. This doesn't rise to the level of an anxiety disorder, but it's pretty prevalent for some people to, or it's pretty prevalent for people to be experiencing anxiety. This is over ages. So the dark blue is younger and the light green is older. And we can see here that the percentage of adults who experience anxiety decreases with age for all levels of severity, mild, moderate, and severe. And there can be a lot of reasons why this may be that we may see this. And one of those things is just experience that we learn coping skills and we learn how to manage anxiety the longer we've had to do it. So this typically decreases with age. If we look at gender differences, women are more likely to experience anxiety than men. So women are in green and men are in blue, and that's across all levels of anxiety as well. So that kind of idea of hysteria that Hippocrates was talking about may have been more focused on women because women in general do experience more anxiety. So if we look at the DSM-5 criteria for generalized anxiety disorder, this is typically how the DSM-5 criteria read. So what it says is excessive anxiety or worry occurring more days than not for at least 6 months about a number of events or activities. So that's already kind of a lot of stuff in just one criterion. Um, the individual finds it difficult to control the worry. And then kind of what are the symptoms that come out of the anxiety or worry? So they're associated with three or more of the following six symptoms. And at least some of the symptoms have been present more days than not for the past 6 months. So things like restlessness, feeling keyed up or on edge, being easily fatigued, difficulty concentrating, irritability, muscle tension, sleep disturbance. Um, so it's kind of talking about these symptoms that people experience because of their elevated levels of anxiety, and this has to be going on more days than not for 6 months. And then it has to cause clinically significant distress or impairment in areas of functioning. That is true for all of our DSM 5 diagnoses. And I think that that's where a lot of us have experienced anxiety, but may have not experienced an anxiety disorder because it doesn't impair us. And sometimes anxiety motivates us. If we're preparing for a project or a test or something for work, it motivates us as we get more and more anxious rather than impairs us. But with anxiety disorders, the anxiety becomes impairing to the point that they aren't able to function in certain areas of their life. And then criteria E and F are in basically all of the criteria for disorders in the DSM-5. So it can't be attributable to substances or other medical conditions, and it's not better explained by something else, other medical conditions or other psychiatric disorders. That's what E and F are saying. So that's kind of the criteria. That's how it reads in the DSM-5 for generalized anxiety disorders. If we look at what's going on in the brain in anxiety disorders, we see this is a kind of a side view of the brain. And we know that we are supposed to have certain responses to things. So if we see like this bear, or we see somebody who's very angry, or we're being shocked in some way, we should feel a certain level of anxiety around that. It is important to have kind of this fear about certain things that are potentially dangerous. However, in people who have anxiety disorders, this is too strong. The fear is provoked when it should not be. And so where we find that is in a part of the brain called the amygdala, which is a part of the limbic region of the brain. And the amygdala kind of screams when something happens that really shouldn't be that fear inducing. And then the cortex, which is basically the kind of wrinkly part of our brain that is supposed to kind of moderate some of these more instinctual innate feelings that happen, this cortex cannot normalize or cannot kind of tamper down this limbic response. And so then we end up kind of with these feelings of fight or flight, freezing, avoiding, and those are very much the symptoms that people with anxiety disorders experience quite often. If we look at the neurochemicals that are involved, we see that it's kind of a mixture of norepinephrine and serotonin. The two of those in kind of in dysregulation can cause anxiety. And so our medications target those things. So our first kind of line medication for anxiety disorders are antidepressants, which target the serotonin and or norepinephrine chemicals. So the SSRIs are selective serotonin reuptake inhibitors, are working on the serotonin system, and the SNRIs are serotonin and norepinephrine reuptake inhibitors. So working on both the serotonin and norepinephrine kind of systems in the brain. That's our mainstay of medications. We do sometimes use as needed medications that are not kind of getting at the root of the anxiety, but can block some of the responses that people have, and kind of tamper down the responses to be able to cope a little bit better. And those include like antihistamines, beta blockers, which are typically used as blood pressure medications, and benzodiazepines. The other piece of anxiety treatment is therapy, that talk therapy that Freud was talking about. Um, in particular, there's a type of therapy called cognitive behavioral therapy. Cognitive is the thinking, behavioral is the behaviors, and kind of putting those two together to figure out how kind of your actions, your moods, and your thoughts are related, and how they interact, and where we can kind of intervene to change some things. We also do use exposure therapy for people who have high levels of anxiety towards certain stimuli, like phobias of spiders and things like that. We can do exposure therapy to bring down that level of anxiety after kind of repeated exposures. If I move on to depression, um, I think that a lot of us have also had kind of at least periods of sadness that we may be able to kind of associate with depression. Um, we can talk a little bit about why sadness is not depression, but I want to kind of go through some statistics, the criteria of DSM-5, neurobiology, treatments, and talk a little bit about suicide as well. Um, but once again, in the depressive disorders category, we have a lot of different types of depressive disorder. We're going to be mostly focused on major depressive disorder, but there are other things: disruptive mood dysregulation disorder, which is more in children typically, persistent depressive disorder, premenstrual dysphoric disorder. So that's more for women around their menstrual period. And so there are different kind of categories of depressive disorders as well. I liked this graphic, and so I thought I would share it. Depression statistics everyone should know. So 300 million people worldwide experience depression. This is not a small problem. This is a huge problem, and a lot of people experience it. And I'm guessing that if you yourself don't have depression, many people that you know in your family or friends network do. The median age of onset is 32 and a half years old. So relatively young, people are starting to have depression. 3.1 million people between ages 12 and 17 have experienced at least one major depressive episode in the past year. So, what this is saying is that our adolescents are really struggling with depression. And I'm not going to get too much into the COVID piece of things unless we have a little bit of extra time, but they were hit especially hard in the COVID pandemic. Suicide is the second leading cause of death among people ages 10 to 34. These are our healthy young people, and suicide is the second leading cause of death, and we'll talk a little bit more about that, but that is really striking. Nearly 50% of those diagnosed with depression also have an anxiety disorder. So we just went through some of the anxiety disorder kind of things. If you can imagine having that plus depressive disorder, that is incredibly impairing. Um, Once again, women greater than men, and I'll show another graphic about this, but 8.7% of women have depression versus not 5.3% of men. And depression is very treatable, but over a third of adults don't receive treatment for depression, and that really makes me sad as a psychiatrist, that we aren't doing a good job of accessing people who really need treatment and really need help. So once again, coming from the CDC, nearly 20% of adults experience symptoms of depression in the past 2 weeks, mild, moderate, and severe included. Um, and the percentage of adults who experience depression varies by age. It doesn't have the same kind of um, pattern as the anxiety disorders. So we don't see the same kind of decrease in depressive symptoms from our young adults to our older adults. It's generally a little bit more even, and that's across all areas of severity. And like I said, women are more likely than men to experience depressive symptoms, just like with anxiety symptoms, with women being in green and men being in blue. And so if we look at the criteria for major depressive disorder from the DSM-5, um, I'm not going to include kind of some of the other pieces, the E and F from anxiety, the anxiety disorder, but I think that this is the meat of the diagnostic criteria here. And that is 5 or more of the following symptoms during the same 2 week period, and must represent a change in previous functioning. And at least one of the symptoms has to be a depressed mood or a loss of interest or pleasure, as those are our hallmark symptoms of depression. It can look different from one person to the next, but we have to have one of the two of those. So the criteria are depressed mood most of the day, nearly every day, which can include feelings of sadness, emptiness, hopelessness, tearfulness. In children and adolescents, this can more times look like irritable mood rather than kind of this sadness. A markedly diminished interest in or pleasure in many activities. We can see a change in weight with a change in appetite. Um, Change in sleep with insomnia, inability to sleep, or hypersomnia, sleeping too much. We can see psychomotor agitation or retardation, which is when people kind of feel like they're stuck in mud, is kind of this retardation. They feel like they're being slowed down, or this agitation of restlessness and things like that. Change in energy with fatigue or kind of loss of energy, feelings of worthlessness or excessive guilt, difficulty with concentration or thinking, indecision, and recurrent thoughts of death, or actually suicidal thoughts or suicidal actions. These are the criteria for major depressive disorder. Do I have a question coming? I think that I heard somebody get unmuted. No? Okay. I will keep going. So those are kind of the criteria for major depressive disorder. And if we look at the neurobiology, so this is one of those PET scans. So PET scans kind of look at the amount of glucose that's being taken up by the brain, and it kind of lights up when there's a lot of glucose that's being used. It looks similar to the functional MRI, and it has a similar thing that it kind of lights up. And what you can see on the right is the person who doesn't have depression, a lot of parts of the brain are lighting up. They're active, they're interacting, whereas people who are experiencing depression really have kind of this underactive brain. It's really, the connections are not working well, the activity in the brain is less. Um, so that's what we mean by underactive cortex. The parts of the brain that should be really functioning at a high degree are kind of slowed down. There's this overactive limbic system, which is that same system that we were talking about with anxiety, kind of this amygdala that has this fear response. But rather than kind of having this externalized response, it's more internalized. It's turned more inwards. And in general, kind of this disrupted connectivity that parts of the brain aren't communicating well with one another. If we look at kind of the chemicals that are involved in depression, we're thinking about serotonin and norepinephrine again with some dopamine. And so it's kind of all three of these chemicals can be related to depression. And so once again, we're going to use antidepressants to help out with the serotonin, the norepinephrine system, so the SSRIs, SNRIs. But sometimes we use additional medications like antipsychotics. Antipsychotics are impacting the dopamine system. And that way we can sometimes use an antidepressant and an antipsychotic together to help see an improvement in depressive symptoms. We also sometimes use mood stabilizers, things like lithium and Depakote, to help with mood as well.
I have a question.
Yeah, absolutely.
There was a special the other week that a psychiatrist was looking at mass murders like Dahmer, and they were cutting, doing the brain, both MRI and cutting it apart, and they found they all had too much serotonin, and we're giving people serotonin when they're depressed, but it might be a mistake.
Yeah. So that's a really interesting it's a really interesting finding. So the kind of mass murderers are a select population that I think a lot of people are very interested in. I am for sure. And trying to kind of study their brains and what's different about their brains from kind of a more normal brain. I would say that most people would say that mass murderers are not depressed. They don't have depression. And we would also kind of point out that the medications that we're using that are inhibiting kind of the reuptake of serotonin or increasing the serotonin levels are not increasing them to kind of superhuman levels. They're increasing them back to normal. And so what we can sometimes see is that with people who are depressed, they have lower levels of serotonin. We're just trying to get those back to normal. But there is concern about going too high on serotonin. Doesn't typically lead to, or it doesn't lead to kind of mass murders or things like that. But there is this idea of, what if we have too much serotonin? Typically, too much serotonin, when we see it, it kind of lands with some more medical things that people feel really crummy. They feel like they're sick, things like that. And we can get something called serotonin syndrome, but they don't have this violence that would be kind of found with criminals in that way. And there's such a select small population of people who are mass murderers that it is difficult to study exactly kind of what is the cause or what is related to that. So it's a really good question, and I think that I hope we learn more about that during during my career. But clinically, from a clinical perspective, increasing the serotonin does not lead to more violence or things like that. Does that help address that? Okay. All right, so we talked a little bit about the chemical piece of things, but once again, a part of depression is therapy, cognitive behavioral therapy. I'll say again, that's kind of our mainstay therapy and can be very effective for depressive disorders, similarly to anxiety disorders. There are a lot of other types of therapy, though, as well. Psychodynamic psychotherapy, there's acceptance and commitment therapy, dialectical behavioral therapy, all kinds of different therapies, and many of them have great evidence for depression and anxiety. And then I put down here neurostimulation. Those are the things like ECT, the shock therapy, TMS, the magnetic therapy. And those are typically used as treatment for treatment-resistant depression. If we use our medication and seem to kind of be running into a wall and the symptoms don't seem to be improving, sometimes we'll go to those more neuromodulation treatments. I do want to just mention that this is for major depressive disorder. There are other types of depression, like bipolar depression, that is treated differently than major depressive disorder, but major depressive disorder is much more common than bipolar depression. Here are some medications, our kind of top 10 antidepressants, just to kind of get an idea of what medications I'm talking about. So bupropion or Wellbutrin, citalopram or Celexa, duloxetine or Cymbalta, escitalopram or Lexapro, fluoxetine or Prozac, mirtazapine or Remeron, paroxetine or Paxil, sertraline or Zoloft, trazodone, venlafaxine or Effexor. I'm guessing that people have heard of some of these medications. Once again, these are first-line treatments for both anxiety and depression, and some of our other disorders as well, things like PTSD, post-traumatic stress disorder, and some other disorders as well. I did want to talk about suicide because I think that's an important potential outcome of people who are really struggling with mental illness. So if you look at kind of circumstances surrounding suicide, I think that these are some interesting statistics. So only half of people have a current known mental health problem who attempt suicide, which once again is really concerning for me because we are missing a lot of people who could be potentially treated and they are not necessarily accessing treatment. Only a third of people had a history of suicidal thoughts or plans that they had expressed to somebody else. So, two-thirds of people attempt suicide and they have never kind of expressed this before. About a third have had a crisis that happened recently, which kind of lends to some impulsivity that people can be reactive and attempt suicide in the setting of a crisis. There can be intimate partner problems in about a quarter of people who attempt suicide, physical health problems in about a quarter, and then substance use, alcohol or other substance use in about 20%, and job problems in about 10%. So I think these are interesting kind of things that might be circumstances that people are faced with that end up attempting suicide. As we talked about before, it's the second leading cause of death in people aged 10 to 34. So our younger people, that's only after unintentional injury. And we know that adolescents and young adults can do some stupid things, and can sometimes be dangerous and get themselves into trouble and potentially end their life. But suicide is the next leading cause of death for these people. It falls down the list as more medical problems kind of creep up. But as we'll talk about next week, ages 65 and older, and actually 85 and older, have an incredibly high rate of suicide. So just because it's not on this list, not the top 10 leading causes of death, because there are other medical things that are kind of causing death in older populations, it is still a really important issue throughout the lifespan. If we look at ages, we see kind of this peak in middle adulthood, and then another peak in older adulthood. And so this is, it kind of comes and goes in terms of rates of suicide based on age. And then these are methods of suicide, of suicides completed for males. So I split up males and females separately because they use different methods. We can see here in the dark blue is firearms. I'm not going to get onto my soapbox about firearms and access to firearms, but over half of people who die by suicide die by firearm. And so this is a really important issue when it comes to suicide, and males use firearms much more often than females. And then the next leading cause is suffocation, which is that kind of lighter blue, and poisoning, which is the medium blue, and then other. Suffocation can include hanging or other types of suffocation. If we contrast this with females, we see that firearms are still there, still very much there, but poisoning, which is like overdosing on medications or things like that, is kind of the leading cause of suicide attempts in females. So if we talk about what are kind of some risk factors and protective factors for suicide, in terms of risk factors, mental illness is certainly a risk factor. A previous suicide attempt is the biggest risk factor, but most people who die by suicide have never attempted before. Serious physical illness or chronic pain, specific symptoms of mental illness, a family history of mental illness or suicide, a history of childhood trauma going back to Freud, that can really impact people in their adulthood, shame and despair, aggression, impulsivity, a triggering event, that crisis, that life crisis, access to lethal means, that's really firearms or large amounts of medications that somebody could overdose on, especially lethal medications. Suicide exposure, so if somebody in your family, friend has died by suicide, sometimes that can be a risk factor for suicide. Difficulty with kind of flexible thinking, which can be helped with some therapy. In genes, we don't know as much about that, but we do know that there can be a genetic component to suicide, those who die by suicide. Some protective factors include social support, kind of connectedness with community, with friends, with family, strong therapeutic alliance with their medical providers, access to mental health care, a positive attitude about mental health care, coping skills, problem-solving skills, cultural and religious beliefs, and just overall resilience. So that's kind of addressing depressive disorders. Before I get into psychosis, are there any questions about anxiety, depressive disorders that you guys have?
Marissa, I have a
Mhm.
question on the suicide statistics that you presented.
Mhm.
There seemed to be a peak at middle age and
Mhm.
another peak in geriatric populations.
Mhm.
I was wondering on the geriatric populations, and I don't know if there's any literature on this. I'm sure there probably is. Could that be related to an aggregate of physical disabilities that evolve as we age,
Yes,
or
absolutely.
being a burden to the family?
Absolutely. So there are certain things about older adult kind of experience that do increase the risk of suicide. And you're actually foreshadowing what we're going to be talking about next week. So we will talk about kind of what goes into why that peak is happening in older adults, and also what we can do to kind of help decrease that risk. But you're absolutely right. Those are two factors that are increasing risk of suicide in our older adult population.
I was speculating, I didn't know.
You're absolutely right. The evidence supports you.
Good.
Any other questions about anxiety disorders, depressive disorders, suicide that you guys want to ask? You can always hold questions to the end as well. Okay. So I will move on to psychotic disorders. I think that this is something that oftentimes people are a little bit less familiar with, and we can talk about why that is. But let's go through some statistics, the DSM-5 criteria of schizophrenia, which is kind of the most common psychotic disorder, talk about the neurobiology and the treatments of psychosis. I do want to mention that in the chapter of psychotic disorders is actually called schizophrenia spectrum and other psychotic disorders. So schizophrenia is already right in that title. It does have one personality disorder, which is the schizotypal personality disorder, which is a very interesting personality disorder that's quite rare. But then we have some other types of psychotic disorders: delusional disorder, brief psychotic disorder, which is very short, schizophreniform disorder, which is a little bit longer, schizophrenia, which is kind of the longest psychotic disorder, schizoaffective disorder, which is kind of psychosis plus depression or plus bipolar disorder. And so once again, several different psychotic disorders that are in this chapter. Some statistics on psychotic disorders. So about 3% of people in the US experience at least one psychotic episode during their lives. So contrast this with, 15% with anxiety symptoms, 20% with depressive symptoms over the past couple weeks. And now we're talking about 3% during their lives. So this is much less common than anxiety and depression, which is why you're probably a little bit less familiar with it. We can talk about when psychotic episodes first happen typically, but about 100,000 teens each year experience their first psychotic episode. So this can happen quite early on in life. And the average age of psychosis onset is 24. Contrast that with 32 and a half for depression. So this can be starting quite early. We typically think of kind of adolescents and young adults as the first episode of psychosis if you're going to have a psychotic disorder. Going back to the CDC statistics, we're looking at men and women. Once again, women in green and men in blue. Unlike anxiety and depression, we're actually seeing that men are more likely to have psychotic disorders than women. And so this is visits to the emergency department with psychosis. And then we can also see over age that it kind of, that the number of people experiencing psychosis kind of goes up and then down for the most part. And that may be partially due to people with chronic psychotic disorders typically, unfortunately, don't live until being older adults because they often have other kind of medical comorbidities that come along with things, often don't function to their highest degree and may not be able to kind of function and take care of themselves appropriately, which leads to sometimes an earlier death for people who have chronic psychotic disorders. If we look at age of onset, this is kind of what I was talking about. So men, we typically see that their age of onset is like in their early 20s, typically. Women, you see a little bit less of that kind of really big peak, but the first episode of psychosis usually does occur during early adulthood, and men are nearly twice as likely to develop psychosis as women. If we talk about schizophrenia kind of as a whole, this is oftentimes what the course of schizophrenia looks like. So from birth to like kind of through puberty, kind of no symptoms. They're kind of generally normal kids, do normal things. We often see kind of this prodromal kind of these prodromal symptoms from like during high school years until early 20s. And what this looks like is kind of this social withdrawal. They don't typically kind of take care of themselves in the same way that maybe their peers might, but they don't have kind of these overt psychotic symptoms that we'll talk about in the next slide. Then from like mid 20s to mid 30s, they have this course often that is kind of very up and down, that they have kind of decompensation and they have these kind of really severe symptoms. And then they often are come into the hospital or have touch base with medical professionals, get back on medications, and they return back to some level of functioning, but it's not typically as high of a level of functioning as they previously were at. And then there's another decompensation, and then when they come back to a certain level of functioning, once again, not quite as high as it was even before the last episode. And so we kind of had this deteriorating course that is progressive. And then by mid 30s or so, we kind of get into this more chronic kind of chronic presentation that most of the time they're having these overt psychotic symptoms. They may also have negative symptoms that can look a lot like depression, kind of apathy, not really wanting to engage. They can have cognitive symptoms. Often people who have chronic psychotic disorders have a decrease in their IQ over time, and they can get these cognitive symptoms. And the functional disability can be quite prominent by this age and through the remainder of their life. So what our medical system should be moving towards, and other countries do this better than we do, is really pouring in resources in the prodromal phase or in that first episode of psychosis to try to improve the outcomes during the syndromal and more chronic and residual phases. So I've been talking about psychosis, and some of you might not know exactly what I'm talking about. So if we look at the criteria for schizophrenia from the DSM-5, we see that 2 or more of the symptoms must be present for at least 1 month. And they have to either be, one of the symptoms has to be 1, 2, or 3. So hallucinations, we'll talk about some types of hallucinations, but that's often seeing or hearing things that other people can't see or hear. Delusions, which are ideas that other people don't ascribe to. They can be bizarre or they can be non-bizarre. So things like, an alien is living in my house or something like that might be a bit bizarre. But they can also be a little bit like more non-bizarre, like, my mother wants to kill me. That's not super bizarre. Disorganized speech, which I'll show you some examples of. Oftentimes their speech can be kind of all over the place and very difficult to follow. Grossly disorganized or catatonic behavior. So people can behave in this very unpredictable, disorganized way, kind of disrobing, taking their clothes off, running down the street, maybe showering and putting lotion in their hair, things like that are quite disorganized. And then the negative symptoms, like I kind of talked about, that are more kind of these depressive symptoms, kind of this kind of flattening of their mood and how they express themselves. So these symptoms have to be over the last 6 months, and there has to be dysfunction, just like in any other criteria that we have. So if we look over at kind of the types of hallucinations, so the most common are auditory hallucinations for people who have psychotic disorders. So that is often hearing voices, static, music, knocking, noises. The voices are often quite distressing. They can be commanding them to do things, to harm themselves, to harm other people, or sometimes just to do mundane tasks like wash your hands or go get dressed or brush your teeth. They can also be quite derogatory and call the person names or things like that. They're usually quite distressing. The second most common type of hallucination is visual. So people can see kind of ghosts, shadows. They're typically not super well formed. They're not like full animals or full people or things like that. It's typically a little bit more kind of opaque. And then the last 3 are kind of less common. So tactile, we can sometimes see of like spiders or insects crawling, blood or water dripping. They can feel that kind of on their skin when it's not really there. Olfactory is smelling. So olfactory hallucinations are hallucinations that people smell. Typically, if we are seeing olfactory hallucinations, we're not typically dealing with psychosis. We might be dealing with more of a neurological disorder like a seizure or stroke. And then gustatory, which is taste. So some people can have kind of these hallucinations of tasting something that isn't there. Once again, typically not as common with psychosis unless you have other types of hallucinations or delusions. If we talk about kind of common delusions, we see kind of persecutory or paranoid delusions that people are out to get them, trying to harm them, monitoring them, poisoning them, watching them, things like that. Grandiose delusions that they are the president or ruling the world or have some theories on things that they do not, or are a celebrity or things like that. Erotomanic, that's the delusion of love, so that somebody loves them, like, some celebrity is wants to be with them, and they may try to stalk this celebrity, believing that the celebrity really loves them or wants to be with them. Jealous, which is usually about a partner cheating on them. Somatic, which is kind of physical delusions, that's kind of the most common in women of childbearing age, is that they're pregnant when they are not, and you can kind of prove to them in many ways that they are not pregnant, but they still believe they're pregnant. And then religious, so there can be these religious delusions of kind of a battle of war of evil and good on earth, and love and hate on earth, and that they are Jesus Christ or the Buddha or something like that, which would be kind of a grandiose religious delusion. So to try to kind of demonstrate this, I took a few quotes from a few of my patients that I've worked with in the past month or so. And so I'm just going to read them off to you. So one of them said, that's what opened the light, an accidental fall. I ran, fell in the ditch wet. The keys was the answer. I held up my keys and said, "Don't kill me." So that's kind of hard to understand exactly what this person is trying to communicate. So we would call this disorganized thoughts with some paranoid delusions, because he's worried that somebody might kill him. Another example is, I've been hearing voices again, dark things, demonic things. They say, "I'm going to rape your family. I'm going to do things to your body. There's a gravitational force pulling me down, making it hard to walk. I see orbs, light things floating around." So this person has auditory hallucinations, kind of voices, these demonic voices telling them things that are quite distressing, visual hallucinations of orbs, and paranoid delusions that somebody's going to try to harm their family or do something to their body. Another example, 10 years ago, I was a part of a scientific research study. They put wires in me that emit signals from my head, chest, and hand. I'm being controlled like a robot and losing function of my body. So this is kind of a paranoid somatic delusion that this person has. And then my last one is, a prophecy is happening. Something weird is happening with time and world. My intellectual property is being stolen by quantum entanglement. I'm a genius. I'm plotting the downfall of the Republican Party. I have the theory on everything. I predicted the meteors. So this is once again quite disorganized. There's not a lot of kind of connections between their sentences, and quite grandiose, right? That they're a genius and that they're going to plot the downfall of the Republican Party. Their intellectual property is being stolen. So these are some quotes from patients that I've had recently. If we look at the neurobiology of psychosis and schizophrenia, we're thinking mostly about dopamine. And once again, this is looking at imaging, and the places that are lighting up are the most active places. So we actually see an overactivity, an increase in dopamine in certain parts of the brain, that is leading to these psychotic experiences. So on the left, we see more reds, that's lighting up more, that's more activity in that part of the brain versus the healthy volunteers on the right. If we're thinking about treatment of psychosis, we usually use medications. That is kind of our mainstay of treatment. On the right, I kind of have a picture of the places of the brain that we're targeting. And without getting too kind of in the weeds about this, the dopamine is dysregulated in certain parts of the brain, and we're trying to decrease the amount of dopamine, specifically in the red area, the mesocortical, and the blue area, the mesolimbic areas. And so antipsychotics block dopamine. And so that's kind of our mainstay of treatment. Therapy can certainly be helpful, but probably less helpful than it is in anxiety and depressive disorders. And community support is a really important part of treatment with those with chronic psychotic disorders. So these are typically the people who are more likely to be in those insane asylums or psychiatric institutions and who are now living in the community and being supported by community mental health centers, group homes, and AFC homes, and oftentimes ending up homeless and incarcerated for kind of petty crimes. So I just wanted to kind of put this kind of picture back up here of a bunch of the chapters of diagnoses in the DSM-5. And so some of them that I didn't talk about that I think people may have heard of are bipolar disorder. That's another major disorder that we really we treat a lot. Substance use disorders, so that's alcohol, cannabis, other substances, neurocognitive disorders like dementia, which we'll talk about next week, trauma disorders like PTSD, eating disorders, personality disorders. So these all fall under the DSM-5. Before I kind of move on to the treatment for mental illness, are there any questions that have come up with psychotic disorders or other questions?
We have two questions.
Mhm.
One is from Pat Denner. Could you speak to how the internet has affected or exacerbated mental health, especially with regards to depression and thoughts of self-harm? What's the
Mhm.
latest thought on this?
Yeah, so I would say that it's impacting our adolescents and young adults more than other age groups, and it is a really big issue, especially with social media, because so much of adolescents and young adults, so much of their social interaction is through social media. That really can. And that's when people are really forming their sense of identity. That really can impact them. And it's so anonymous that people just say whatever they want to say, and so it really I don't work with children and adolescents, but that is probably one of the main triggers of a lot of people having decompensation of depression or anxiety, and is typically something that has to be kind of worked around or worked with in terms of the treatment for those disorders. So it certainly is impacting our young adults more than our adults. I would say that just because it's an interest of mine, conspiracy theories are something that is a really interesting part of things, and psychiatrists get asked to comment about conspiracy theorists sometimes. And I would say that the internet has made it really easy for conspiracy theories to spread and people to find like-minded people, and which kind of strengthens the ideas of conspiracy theories. We separate that from psychosis, and that psychosis is not kind of this societally accepted or culturally accepted idea of what's going on, and it typically is impairing their functioning and impacting a lot of aspects of their life. But conspiracy theories have been advanced more with the internet. So I know that that's not what the question was asking about, but it's an interest of mine, so I threw it in there.
We have a second question from Sue and Doug Pretty. I have thought that dopamine was more of a physical, quote, chemical affecting the muscles and such, as in a loss of dopamine causing Parkinson's disease.
Yeah. Yeah, so let me back up to this slide. So dopamine is in all kinds of different places in our brain. And so a lot of people know dopamine as kind of the chemical that causes pleasure, which it does. In certain parts of the brain when released, if we do an activity that's pleasurable, if we have a really great ice cream sundae, a really great time with our friends, if we go on a roller coaster, rush of dopamine, and that's in certain parts of the brain. That is not in the any parts of the brain that are listed here. So oftentimes people think of dopamine as kind of the happy chemical or kind of the rewarding chemical, and it's also known in that realm for substance use disorders, that there is kind of this want for more dopamine, this rewarding chemical with substance use disorders. However, in other parts of the brain, so if you look in the green area on this picture, the nigrostriatal, this is a certain part of the brain that is involved in Parkinson's disease and is related to not enough dopamine in this part of the brain. And Parkinson's disease, we can get kind of the tremor, the slowness of movement, shuffling gait, stooped posture, those kinds of things. And that's with not enough dopamine in that part of the brain, the nigrostriatal area. So it's a good segue to talk a little bit about the side effects of antipsychotics. If we're decreasing the dopamine, we're not selective enough to be able to decrease the dopamine in just the mesocortical and mesolimbic areas. Sometimes we decrease the dopamine in nigrostriatal areas, which means that we can get people who look kind of Parkinsonian, is what we say. They look like they might have Parkinson's disease, but it's because of our medications. Similarly, on the flip side, people who are being treated for Parkinson's disease are typically taking something like Sinemet, which increases their dopamine in their brain, and they can actually have psychotic symptoms. They start to hallucinate, they start to have delusions, and their neurologist will try to tweak their Sinemet to have kind of a level of dopamine that's enough to help their Parkinson's symptoms, but not so much that it causes psychotic symptoms. So that's a really good question. And you're absolutely right that dopamine is involved with Parkinson's disease.
I have another question.
Mhm.
Is sociopathic behavior considered a mental illness?
Good question. So yes and no. So sociopaths, psychopaths would most often fall under what would be considered antisocial personality disorder. There is a chapter on personality disorders which includes antisocial personality disorder. It does not have anything about psychopaths or sociopaths, although forensically that is defined. But most psychiatrists do not believe that to be a treatable mental illness, which is, we would love to have a treatment. We would be ecstatic to have a treatment for psychopaths, sociopaths, antisocial personality disorder, but we don't at this time. And so no medications, no therapy have proven to be effective for it. So typically psychiatrists don't consider it a treatable mental illness, but that group of people typically does fall under a category in the DSM-5.
Suzanne Harrington has her hand raised. She has a question for you.
Absolutely.
Unmute yourself, Suzanne.
I'm not sure if we're having some technical difficulties.
Yeah, it might have been an inadvertent hand raised there, John. I'll try to contact Suzanne and see if she needs any assistance.
Okay, thanks.
Great, thank you. All right, so I will kind of move on to kind of treatment for mental illness. And
I'm back with you.
oh yeah,
I didn't know which one to push. I
No
just
problem.
wanted to know, is there an age that they think mental illness can really express itself from birth to whatever?
yeah, so it depends on the kind of the disorder that we're talking about. So typically we can certainly see some mental illness in children and adolescents, but typically we're thinking more around the age of puberty that we start to see more of these psychiatric disorders. And then yeah, for a psychosis we're thinking kind of early 20s is the most common time for early onset or kind of first episode psychosis. And then kind of depression, anxiety can come throughout the lifetime. But the kind of average age is around 32 or so. So there are certainly people who are experiencing these symptoms, in adolescence, and there are other people who don't experience them until late adulthood. So there's not like a, if you pass this age, you're never going to have a mental illness. I wish that did happen. But it depends on kind of the illness.
Okay, I just wondered about before you get to puberty, whether there was anything that was significant. Thank you.
Yeah, there certainly are some things that are more common in children than adults, and there are certain diagnoses like oppositional defiant disorder, conduct disorder. Those are things that are kind of leading up to more of that sociopath, psychopath, antisocial personality disorder that we see more in children and adolescents. But in terms of kind of the depression, anxiety, it certainly can pop up, but it's usually a little bit after puberty. So talking about kind of treatment modalities, we talked a little bit about this already, but um, we try to look at mental health and mental illness from kind of this biopsychosocial model, so that there are biological pieces like their physical health, disabilities, genetics, neurochemistry, so the chemicals in the brain, immune response that are kind of playing into a mental illness. There's a psychological piece of like, the beliefs that the patient has, the person has, behaviors, personality, who they are, their character, their self esteem, their coping skills, emotions, social skills, and then social and environmental pieces of kind of peer relationships, families, cultural traditions, social supports, and then kind of how these all come together. And so, from a biological piece, we've talked about medications, we've talked about neuromodulation, the ECT or TMS. There's also substances like alcohol, cannabis, other substances play into mental health and can cause some of these depressive anxiety disorders. Psychosis we can see with methamphetamine use, cocaine use, cannabis use. So that's a biological piece. Physical exercise and diet, we'll talk a little bit about that more next time, but that certainly is a biological piece that can impact mental health. Genetics, that is kind of cutting edge right now. So we don't have as much information about genetics as I think we would like to. And that is certainly an area of research that is very much expanding right now. From a psychological place, we try to kind of attack that with therapy and social skills training. So the therapy can be this cognitive behavioral therapy or other types of therapy, individually or with groups. Couples therapy is a part of kind of the psychological and social part of things. So kind of couples and family therapy, case management. So case management is a part of our community mental health centers often that help people kind of manage things in life, in their social life, in getting to the grocery and in kind of making sure that their house is clean and those kinds of things. And then engagement with social supports and religious communities. That's a really important part of things. And loneliness is an independent risk factor for suicide. So if we can just have social connections, that can really go a long way. I've already showed this slide, but I wanted to show it again because it kind of brings us full circle. So the history of mental illness, the history of mental health treatment, like we kind of talked about, ECT still being used. Lithium, that's a mood stabilizer, that's still being used for depression, bipolar disorder. Thorazine or chlorpromazine, antipsychotic, still being used. So I think that one of the things about this slide is 1985 is the most recent that I have on here. And that's because we haven't had any major breakthroughs in the last few decades. There have been a couple things, ketamine, if people have heard about that. There's a new medication for postpartum depression as well. But really trying to find new and novel ways to treat depression, anxiety, psychosis. That's what we're all looking for. That's what we really want. So I wanted to just show this slide because I think that this shows kind of that biopsychosocial kind of piece of things as well. So on the right, you have kind of genetics and kind of what happens as an individual growing up in school, in the workplace, with family, kind of their strengths as a person. And then on the left in the green is kind of these societal things like, what is your physical neighborhood like? Is it a safe or unsafe place? Is school a comforting place for you, or is it a scary place for you? Kind of their social and economic context. Are you somebody who is a minority in multiple ways? Are there laws that are against kind of your beliefs? How is the media? Here is a part of the media here. How are we being exposed to the media and how is that impacting us? And the service system, how is our kind of network in our country appropriately kind of helping us, or is it harming us? And so I think that, kind of in the middle, we see that negative kind of exposures as a young person can cause negative kind of ways that we think and behave and feel about ourselves and others, and eventually can kind of trickle down to this adult mental illness. If we can intervene in any of these areas, our outcomes are going to be better. And then the last piece of things, which is really sad, is adult mental illness is more likely to kind of have this negative outcome for the next generation, because once again, these factors, individual factors passing on genetics, societal factors, these factors are going to continue to trickle down. So our hope is that we can kind of intervene in some of these places. So I just wanted to kind of show, this is my last couple of slides about kind of mental health versus mental illness. And I think that the big takeaway here is that mental health allows us to kind of function in all spheres. So resiliency to stress, empathy, optimism, stable relationships, respect for yourself and other people, a sense of belonging, clear thinking, self-confidence. Those are the things that go along with mental health that those with mental illness really struggle with. And I think that, this next slide also shows kind of what we can do to try to maintain good mental health, which we'll talk about also a little bit next week. But eating healthy, staying positive, getting enough sleep, maintaining a work-life balance, being physically active, connecting with others, reaching out when we need help. I think that that's one of the main things that those with mental illness don't always feel comfortable. And those who don't have mental illness, who are struggling a little bit, could still benefit from some extra support. So this is kind of my last slide about maintaining mental health. So kind of minimizing substance use, tobacco, alcohol, cannabis, other substance use, engaging in physical activity. The recommendation is 3 to 4 days a week, 30 minutes at a time of at least moderate physical activity. I believe strongly that everybody should be engaging in this level of physical activity. And if you have physical limitations, you can adapt that. But we can be doing chair exercises, we can be doing arm bikes if our legs aren't strong enough to be walking or things like that. Eating a well-balanced diet, we'll talk next time about specifics about that. Maintaining a healthy weight, managing chronic medical conditions, maintaining connectedness with supports and community, engaging in activities that provide leisure and that provide purpose. I think that one of the things that people with depression often say is that they don't feel like they have a purpose, they don't have a passion. And so engaging in activities that provide that can be really helpful. So these are some resources that I think everybody should know about and everybody should have access to. The National Suicide Prevention Lifeline, you can just dial 988. It's like 911, just 988 and call, and that is how you call this. This was actually put through in the past year or so to establish that. There's also a crisis text line. There's the National Alliance on Mental Illness, the Substance Use and Mental Health Services, SAMHSA, the NIMH, and then your county's community mental health center. They're there for you. And so you should access them if you need kind of mental health treatment or don't know where to go. They're a good first place to go. So here are my references, and I know that we're just about out of time, but I am available for any questions, and I'll be back next week. So if there are questions that come up over the next week, I'm happy to address those next week as well.
I do have a quick question for you, Sharon Arnsorst here. One is sort of a half comment and then in the question. One is many of us have been parents of a teenager, and you talked about that if we could only intervene earlier. How does one assess what is, quote, normal, erratic, strange, crazy teenage behavior from maybe the beginnings of an underlying illness? And the second part of that leads into this is the accessibility. I am grateful that people cannot just say it's time to send Grandma Sharon to the mental health institution because we're tired of her. But the accessibility for those who really need help, have to be a danger to yourself or others. And intervention can't happen till you're in. If you're not going to access the treatment yourself, there's that terrible place of everyone knows something's happening, yet and they need he or she needs inpatient treatment, and you can't get them there without a whole legal procedure. So how can we make it more accessible to folks who will not access the help they desperately need in an appropriate way, because they think everything's fine because they're psychotic, or thinking grandiose things.
Yeah. So the first part of your question about kind of adolescents and teenagers, we don't come with like an owner's manual of like what's normal and what's not normal, right? And so it can be really hard to know. I think that the best place to start out is actually with a primary care doctor. The primary care doctors have, or pediatrician, can kind of have a knowledge of what is kind of typical, what is atypical, talking to other supports, other kind of families that have similarly aged children, that can be part of it. But it can be really, really hard to know kind of how far do we allow this to go, and what can we even do about it if we don't like the direction that it's heading. And I think that segues into your kind of second part of your question about hospitalization. Because we respect patients' rights and autonomy, we don't want to force treatment upon them unless they are at risk of harming themselves, harming others, or can just not take care of themselves. So there's these kind of balances of ethical principles that we're trying to balance. And we know that one of the characteristics, one of the criteria, even for some mental illnesses, is a lack of insight, that they don't realize that they have this mental illness, which really runs in, we run into this a lot, that this is a real problem. So you're correct that an involuntary hospitalization has to go through kind of the legal process, and that's to protect patients' rights. There's that kind of in between of people who don't want to come in as a voluntary patient and don't meet the criteria of an involuntary patient. And the kind of best thing that I can say is that the more people who love them that say we're really concerned about you and we think that this would be helpful, and you don't necessarily have to say I think you're psychotic, I think you're thinking things that other people aren't thinking, you're hearing things or seeing things that other people aren't, but just you're not acting like yourself, it doesn't, it seems like you're a little out of character right now, you could really use some help. That's kind of the only thing for those people in between. And oftentimes, unfortunately, those people in between end up coming to the level of requiring an involuntary hospitalization when things decompensate further. All right.
I don't see any more questions.
Great.
There's some compliments on your presentation, Marissa,
I appreciate that.
and I'm looking forward to next week and learning more.
Awesome. So we'll be talking about kind of mental health and mental illness in the older adult population. So I look forward to that too next week, same time, same place.
Yes.
All right.
Thank you, everybody. See you next week. Marissa, on a personal note, I had a patient a number of years ago, he was middle-aged. He had overcome substance abuse and he was doing okay. And then some things started going south in his life. And he came in, and it was a Friday, and he just seemed like he was saying goodbye to me.
Mm-hmm.
And my wife picked up on that too. We talked about it that evening at dinner. I thought, I'm gonna call him Monday. And on Sunday, I read his obit.
Mm-hmm.
It just struck me hard that I didn't recognize it or act quickly enough. And it just bothered me my whole life.
Yeah. I mean, I think it's so hard to know, right? Because I think, when you look back on those interactions, you can identify that, um, oh, I should have done something. But how many times does something like that happen that you do nothing and nothing happens? I think that um, talking about suicidal thoughts is really uncomfortable for a lot of people. Our data shows that it doesn't increase suicidal actions or suicidal thoughts in any way. And so I think that it's always important if there's anything that feels off, like, hey, trying to touch base about it. But it's such an uncommon, it's such a rare thing to happen. And it's such a final thing that if you know somebody and you feel like you could have intervened, I'm sure there's a million other people who feel like they could have intervened too. And it's so hard to know because it's such a rare outcome. It's such a rare thing that happens, and things like that happen in our day-to-day life. And um so it's so hard. I think a lot of people have had a similar experience, unfortunately, of feeling like, ah, if I only knew, or if I only read into that in the way that my gut was kind of, feeling about it, maybe something different might have happened.
If I called immediately instead of waiting 48 hours, that kind of thing.
Yeah, and who knows, right? I mean, who knows what would have happened even if you talk to him, you know was his mind already set that that was what was going to happen? um
Would I have been able to change his mind, do you
right.
think?
Yeah. Yeah. um
Is it
Hard to say.
possible?
Yeah. Yeah. Hard to say.
Well, I never
Marissa,
forgot.
I have a question.
Mhm,
Are you still there?
mhm.
Are you still there?
Yes, I am.
Oh, I was a therapist in a high school, and we used to, when they would have hospitalize the kids, they stay like 5 weeks or more and really get it, straightened out or in a suicide floor. And my daughter's a social worker locally, and she said after COVID, she might have 5 kids a week that needed hospitalized, but they stay there like 3 days and they could get out. Didn't do any good except get them out of a bad situation at school.
Yeah. Yeah. So if we have some time next week, I can certainly touch base on some of the statistics from COVID and its impact on mental health. But there certainly has been a spike after, kind of in the aftermath of the original pandemic in early 2020. Um, and yeah, inpatient hospitalizations are typically a lot shorter than they were previously. There are a lot of people who need inpatient hospitalization. So, kind of the resources are such that if people stayed for a long time, we wouldn't be able to serve as many people as they is needed. I know that John was just mentioning kind of the barriers to treatment. One of them is insurance. Insurance sometimes dictates how long people can be in the hospital, or else they would have to pay out of pocket to be in the hospital, which is incredibly expensive and just it's prohibitive. And so insurance is kind of in some ways pushing this bill a little bit, of how long people stay in the hospital. So yeah, the average length of stay in our hospital is maybe 5 to 7 days. On my unit with patients who are more psychotic or manic, it's a little bit longer. On some other units, it's a little bit shorter, but it's certainly not the weeks long stay that it was historically.
Thank you. Good talk. Very good talk.
Thank you.
I
All
think
right.
think we can close it down.
All right. I'll see you guys next week.
Run well